So now I want to shift focus a little bit and briefly discuss brain metastases. The treatment for brain metastases is highly individualized and is changing fairly rapidly. So again, these are cancers that do not start in the brain. They are cancers that start outside of the brain but have spread to the brain. And the main issues that we have to deal with in determining a treatment course is what the primary disease is, the number of spots or lesions in the brain, the size of those lesions, the location, and then what, again, the performance status is, or how well the patient is able to carry on activities of daily living, and then what the patient's symptoms are. Sometimes we resect these surgically, so if there's a single large lesion and a patient who's very symptomatic, the surgeons will often remove it. That's the fastest way to remove the pressure on the surrounding brain tissue. Often we will do whole brain radiation. So if there are many lesions and they're scattered well throughout the brain, we often will treat the entire brain, and that's typically done in 10 treatments. And then depending on the scenario, we often do stereotactic radiosurgery, and again, this Dr. Sim will be focusing on in a little bit, but there we treat just the spots that we see, and we give minimal dose to the surrounding normal brain tissue. And I think as a whole movement, radiation oncology is moving more and more towards stereotactic radiosurgery rather than whole brain radiation, although certainly we still use both modalities. But as our treatments for the cancer outside of the brain has improved, we believe that often using stereotactic radiation decreases a lot of the long-term toxicity that is associated with whole brain radiation. So although we've made nice advances, there's certainly room to improve. So where are we headed in the future? Really, I believe a lot of it will be to incorporate a lot of the newer biological imaging into the treatment planning. And what I mean by that is, for example, if we were, there's a ability now to scan a brain on an MRI called MR spectroscopy. So instead of just using pictures, where here we see this white area that we know is abnormal, but if you look at this area above the white area, it looks fairly normal. And then we can do a spectroscopy scan, which looks at chemical signals given out by the brain tumor cells. And based on those chemical signals, we can see that this red area actually is quite abnormal based on chemical signal, even though according to our ability to image the area, it looks normal. So as we progress, what we will be able to do is start to incorporate this knowledge into our treatments to know that we not only necessarily target areas that look abnormal, but we have other ability to determine other areas that may be abnormal even though they look like they are normal, and that will further improve our ability to treat brain tumors.